So the discussion today is we are continuing with the opioids. The discussion specifically today is the remaining effects of opioids. All, this is Dr. Mubin Sayed from Drbeen.com. Welcome to one more show. So the discussion today is we are continuing with the opioids. The discussion specifically today is the remaining effects of opioid, except the cardiovascular effect. So we would have many systems and the opioids effect on them. I want to wrap up the opioids mechanisms and effects by today's talk. If I had drawn and presented them, this would have taken a long time. So just the summary points of every system. After this, then we would go into opioid use disorder, substance use disorder, smoking use disorder, then the management of opioid use disorder, and then the alternatives to pain. So that is the plan. Let's start our discussion, mostly going through the summary points with a PowerPoint. So get ready for this. Okay, so more effects of opioids. I have no disclosures. Objectives of today's talk. We're going to talk about the effects of opioids on exacerbating factors for opioid-induced respiratory depression, opioid-induced hyperalgesia. And you may actually recall that I did a complete topic of paradoxical hyperalgesia or increased sensation of pain with opioids. I have actually touched upon that in the previous lectures. Sedation and the effect of opioids on sedation, neuroendocrine effects, effects on sex hormones, meiosis, seizures and convulsions, cough, nausea, and vomiting. So these are the topics for today. So let's start. First one, exacerbating factors for opioid-induced respiratory depression. So think about it. We have talked about opioids before, that they cause or they can cause respiratory depression, right? And we have looked at the mechanisms. So here, exacerbating factors. So for the respiratory depression, what other factors can actually aggravate that situation? So here, number one, interaction with other medications. Combining opiates with other depressant medications like general anesthetics, tranquilizers, alcohol, sedative hypnotics can result in an increased suppression of respiratory activity. And I think it is kind of makes sense. Anything that would cause respiratory system depression, anything that would cause muscle relaxation, anything that would cause neurological system depression, these all would then augment or exacerbate opioids effects, respiratory effects. Then impact of sleep. Natural sleep decreases the sensitivity of the medullary center for carbon dioxide. So you have seen the medullary carbon dioxide centers, we have talked about it as well. That really is a hydrogen ion sensing centers. And then they would help the breathing. But opioids depress that center. Now, when somebody is sleeping, sleeping also reduces the sensitivity of that area. So if they're sleeping, they also have opioids, then that becomes a cumulative effect. So natural sleep decreases the sensitivity of the medullary center for carbon dioxide, and the depressant effect of morphine and sleep are at least cumulative. They're additive. Obstructive sleep apnea is considered a significant risk factor for increasing the chances of fatal respiratory depression. So COPD and opioids may have, there is an increased risk of fatal respiratory depression. Then age-related factors. Newborns may exhibit significant respiratory depression and desaturation, which could be reflected in lower APGAR score if opioids are administered intravenously to women within 2 to 4 hours of delivery due to transplacental passage of opioids. So opioids can cross placenta. So if a woman is given opioids before delivery, 2 to 4 hours, then the opioids are going to cross placenta, go into the baby's system, and cause respiratory depression in baby. Elderly patients are at a higher risk of depression because of reduced lung elasticity, chest wall stiffness, and decreased vital capacity. So this is also important. It's not that elderly patients generally respond more to opioids, but their body, their bones have become more stiff, their chest wall movement is reduced, their lung compliance or elasticity of the lung has reduced. Then if you add opioids on top of that, that will become an exacerbating respiratory depression factor. Then impact on patients with chronic diseases. Opioids may have more pronounced depressant effect on patients with chronic cardiopulmonary or renal diseases because they can develop a decreased responsiveness to elevated carbon dioxide. So such patients may have decreased responsiveness to carbon dioxide. For example, in COPD, the patient does not respond as well to increased carbon dioxide as a healthy person does. If you add opioids on top of it, then the respiratory depressing effect will become additive. And as I said before, it could become fatal, especially in COPD. Sleep apnea. So patients with COPD and sleep apnea may experience enhanced respiratory depression due to diminished hypoxic drive. So same point, now we are saying it for the third time. Hypoxic drive is that when the oxygen levels are less and the patient is, or a healthy person responds to them by increasing the breathing. But in these patients, sleep apnea patients, COPD patients, they are not responding as well to reduce oxygen and increase carbon dioxide as a healthy person will be. Now, if they have opioids on top of that, then that would be a cumulative or additive effect. Pain relief and respiratory depression. This is a very interesting point. Think about painful situation. Sometimes when we are in pain, our respiration increases. Pain causes respiration to increase. And again, everybody's threshold is different. It's not necessary that everybody who has pain anywhere would have increased respiration, but pain can contribute to increased respiration. Now, when you give opioids have their own respiratory depressant effect, correct? As the opioids reduce pain, the respiratory drive because of pain will be eliminated. So there could be that exacerbating effect of respiratory depression. Then opioid-induced hyperalgesia, increased pain. Do you recall that we talked about it, the paradoxical effect of opioids, that the patient actually starts feeling more pain than less pain? This is what we're talking about. A paradoxical escalation in pain conditions has been documented in response to both acute, hours to days, and chronic exposure to opiates. We actually did this talk with the mechanism. This escalation can manifest as unexplained increase in pain reports, elevated pain levels with escalating opioid dosage, or a generalized sensitivity unrelated to the original pain source. So such patients may continue to complain that, hey, I have pain. They may actually say that I have pain generally in more areas than where originally they had pain. Let's say they had a surgery. Or as you increase the dose of opioid, they keep complaining that my pain is increasing. So that is paradoxical hyperalgesia because of opioids. The precise mechanism underlying this heightened pain profile remains unclear. However, there is a consideration of an increased excitability of central nervous system pathway as a relevant factor in the context of chronic pain. We have done that discussion. An alternative hypothesis have suggested that opioids exert stimulatory effect on innate immune signaling via the activation of Toll-like receptors 4. Remember that Toll-like receptor 4s are present on the immune cells, ultimately contributing to central sensitization. So this is a very interesting one. I always get fascinated by this mechanism that we use opioids or in certain settings to reduce pain, but in some patients, it can cause increased pain. Sedative effects. Opioids have the potential to induce drowsiness and cognitive impairment. So they can, in some people, cause sedation. And such depressive effect can exacerbate respiratory dysfunction. These outcomes are most typically observed following the initiation of opioid therapy or when the dosage is increased. So this is very important clinical pearl that sometimes when you start patients on new opioid therapy, they may actually have sedative effect. Or sometimes when you increase their dose, they may start having sedative effect. This would also, I think, already tell you that this may be a temporary effect as well. So it is crucial to note that these arousal-related effects tend to resolve within a few days. Similar to respiratory depression, the extent of drug-related impact can be intensified by various predisposing factors in patients. So what is the patient's own situation? What are the drugs they're taking? What is their body's condition? So conditions like dementia, encephalopathies, brain tumors, then concurrent use of other drugs like depressing medicines, sleep aids, antihistamines, antidepressants, and anxiolytics, they all play a role with opioids effects. So opioid in some people may exacerbate their sedation, many times when you just start them or when you increase the dose, mostly temporary. However, it will depend how temporary, it would depend upon the person's pathologies plus the other drugs that they're using. Neuroendocrine effects. This is a really important set of sections, that what is the effect on the hormonal systems and neuroendocrine system. So the regulation of hormones and factors released on the pituitary gland is subject to intricate control through opioid receptors. So pituitary glands controls are subject to the opioid receptors through, there are opioid receptors present there. So opioids can actually go and affect there. So within the hypothalamic pituitary adrenal axis, so HPA axis, so hypothalamus, that is controlling the pituitary, then pituitary is controlling the suprarenal glands or adrenal glands. So this whole axis can fall apart, or that is probably a more bold statement, this whole axis can become disrupted. In a broad sense, opioids resembling morphine are known to decrease the release of wide array of hormones within the HPA axis. This is very important. Morphine-like opioids can reduce the release of hormones from pituitary system. And of course, if that would happen from hypothalamus to pituitary, that would also then involve suprarenal glands as well. And we'll talk about that in a second. Sex hormones. In males, the administration of opioid in an acute setting leads to decrease in plasma cortisol, testosterone, and gonadotrophin levels. So acute setting, somebody went under surgery and then they are using opioids. Such males will have these effects. The impact on adrenal function, so suprarenal, the glands that are sitting on top of the kidneys, the impact on adrenal function is evident through reduced cortisol production and diminished adrenal androgen levels. Females exposed to morphine also experience reduced release of luteinizing hormone and follicle stimulating hormones, or LH and FSH. Quite an impactful effect of opioids on this hormonal system. In both males and females, chronic opiate therapy can lead to endocrine disorder, including hypogonadotrophic hypogonadism. So hypogonadism is ovaries or testicles not working with the correct capacity or even becoming atrophied. In men, this may manifest as decreased libido, and with prolonged exposure, a reduction in secondary sexual characteristics. So the secondary sexual characteristics, for example, these brow ridges in men or muscle, volumes, etc. So there are many secondary sexual characteristics. Those start becoming less prominent. Although you can't change the bones that fast, but still many voice, etc. would start changing. In women, such exposures are associated with irregularities in the menstrual cycle. Importantly, these alterations are reversible upon discontinuation of opiates. So this is important. These are reversible changes. Prolactin. So quick note about prolactin. In women's system, prolactin is actually made in men as well, but of course more in women. In women's physiology, prolactin, or the hormone that helps express milk or that controls the expression of milk, it is actually always ready to be released. However, there is a continuous suppressing effect on prolactin. So we continue to, or the body continue to block prolactin from getting released. And how do we block that? So the anterior pituitary regulates the release of prolactin, and this release is normally suppressed by dopamine release on neurons in the arcuate nucleus. So again, arcuate nucleus is in the brain, and that nucleus releases dopamine. Dopamine causes prolactin release to be suppressed. If you take that dopamine away, prolactin would start releasing, and the woman would start expressing milk. Guess what opioids do? Opioids, mu receptor, are present on the arcuate nucleus, and they suppress the production of dopamine from there, which means that dopamine for the prolactin release is reduced, resulting in prolactin to be increased. So opioid receptors of the mu opioid receptor type exert their influence at the presynaptic levels, where they inhibit the release of dopamine. Consequently, this inhibition of dopamine release leads to an increase in plasma prolactin levels, which could lead to women expressing milk without being in the physiology, for example, having a baby to express milk. So that is the effect on prolactin. So prolactin normally always ready to be released. It is usually kept suppressed, and opioids disinhibit the inhibitory system. Okay, then antidiuretic hormone. So the impact of opioids on the release of antidiuretic hormone and oxytocin is intricate. These hormones are produced within the cell bodies of the magnocellular neurons situated in the paraventricular and supraoptic nucleus of hypothalamus. And they are subsequently released in the posterior pituitary. So I'm going to have to edit that part where I think I said ADH from the suprarenal gland. So they are released from posterior pituitary. Activation of kappa opioid receptors has the effect of inhibiting the release of both oxytocin and ADH, resulting in noticeable increase in diuresis or urine production. So on one end, ADH is reduced. It is important to note, however, that certain agents like morphine may induce hypotension as a secondary effect due to the release of histamine. This hypotension in isolation can trigger the release of ADH. So on one end, direct effect to reduce ADH, on the other end, through the hypotension because of histamine, increase ADH, and the net sum will be zero. Could be zero, but it could be a strange balance, either more diuresis or less diuresis. So that is the effect of opioids on the ADH and oxytocin. Now, meiosis, pupil pinpoint pupils. Remember, you may recall from my previous talks when we talked about opioid tolerance, that there are some tissues that become tolerant very fast, some that take some time, and then there are some tissues that never become tolerant to opioids, and they always respond to them with a high intensity. Meiosis is one such effect. Opioids would always cause meiosis. And actually, that is one of the factors in diagnosing opioid related issues. So, more agonists or mu opioid receptor agonist induce pupil constriction or meiosis when an individual is awake and prevent reflex dilatation of the pupils during anesthesia. So, when a person is awake, pupils are pinpoint, and if you give them anesthesia, they do not get dilated. The parasympathetic outflow from Edinger-Westphal nucleus activates parasympathetic pathway through the ciliary ganglion. So here on the sides of our eyes, or near the, actually not sides of the eyes, near the optic nerve, near the eye, with the optic nerve, there is a ganglion called ciliary ganglion. So there is the parasympathetic pathway present in there. So what happens is opioids act on the Edinger-Westphal nucleus that goes to the ciliary ganglion and leading to pupil constriction. This process is regulated locally by GABAergic interneurons. So what does that mean? We have done this discussion when we are talking about the spinal cord and the pain pathways, that there can be small neurons that connect one neuron to another neuron. So they are kind of intermediates between them. These are called internuncial neurons or simply interneurons. So this process of meiosis is controlled by GABAergic interneurons. Opiates inhibit these GABAergic neurons. When they inhibit them, the result is that there is an increased parasympathetic activity that causes meiosis. And somehow this mechanism, these neurons do not become tolerant to opioids. And we discussed the possible reason for why do they not tolerant. Do you remember that? So at high agonist doses, meiosis is pronounced and pinpoint pupils are a distinctive sign. However, marked pupil dilatation or mydriasis can occur during asphyxia. So this is a very interesting thing. Once respiratory depression sets in and the patient is asphyxiating or they don't have oxygen and they are kind of drowning without oxygen, then the pupil can start dilating. Although some tolerance to the meiosis develops, individuals with high opioid concentrations in their system continue to exhibit constricted pupils. Therapeutic doses of morphine. Therapeutic doses, we're not talking about overdoses. Therapeutic doses of morphine enhances the ability of the eye to focus and reduce intraocular pressure in both normal and glaucomatous eyes. So when the ciliary body is pulled, when the mechanism of eye kind of causes this pinpoint pupil or a smaller pupil, that opens up the canals around the iris and the ciliary body in that angle, which allows the aqueous humor or the fluids that are present in the eye to be drained away easily. That reduces glaucomatous pressure or even normal pressure. Seizures and convulsions. So in older children and adults, higher opiate doses lead to EEG slowing. So EEG slowing means electrical activity of the brain is slowing down. That would not cause convulsions or seizures right away. However, in newborn, morphine can trigger epileptiform activity and occasional seizures. So newborns can have this response to morphine. These excitatory effects, so this is an excitatory effect. Remember, we did opioid, and a lot of effects are also depressant effects. However, opioids have excitatory effects as well. This is one of such an effect. So the question is, how does this happen? So number one, inhibition of inhibitory interneurons. So I'm gonna, if you can see my hands, imagine that this hand is one neuron and this hand is another neuron. Between them is an interneuron that is kind of taking the signal from one and bringing it to the other one. So this is the internuncial neuron or interneuron. There are some interneurons that are inhibitory. That means they would act on a neuron and inhibit that neuron, stop that neuron from activity. Opioids can actually inhibit the inhibitory neurons that causes the other neurons to become excited. There is no one to inhibit them, and now they're doing whatever they want. This excitation can cause seizures and convulsions. So morphine-like drugs indirectly excite specific neuron groups, such as hippocampal pyramidal cells, by inhibiting the usual restraint exerted by GABAergic interneurons. Then direct stimulatory effect. So this is very important and interesting, that we're talking about an effect now where opioids are not inhibiting something, they're actually exciting the neuronal system. Opiates can interact with receptors linked to both inhibitory and stimulatory G proteins. So G protein, remember we talked about the receptors for the opioids and we said that these are serpentine proteins or the G proteins. G proteins can be present for excitation of a neuron or for inhibition of a neuron. G proteins are just receptors. They are like doorbells. You could have a doorbell attached to some house where when you press the doorbell, they would not open the door. And in another house where when you press the doorbell button, they would open the door. So excitation or inhibition can occur based on what is connected with the G protein. Opioids can affect these G protein receptors. And sometimes, think about this with me, sometimes the inhibitory G proteins or inhibitory receptor become exhausted and tolerant faster than the excitatory. So imagine if I am a neuron and I have inhibitory receptors on me and excitatory receptors on me. And if opioids are working on both of those receptors, an inhibitory receptor becomes exhausted first, then excitatory receptor would continue to work and I will become excited. So this is a very big simplification. It's not one neuron, a bunch of neurons take part in this. But the point is, opioid can act on G proteins that are inhibitory or excitatory in the neuronal system. Inhibitory ones can exhaust or become tolerant faster, leaving the excitatory receptors that would cause excitation, which can then cause seizures and convulsions. And then finally, actions mediated by non-opioid receptors. So the metabolites of certain opioids like morphine, 3-glucuronide, or norepinephrine, these are the metabolites, these are the breakdown products of opioids. These products can work on other receptors to cause excitation. So that's not opioid directly causing excitation, but opioids breakdown products causing excitation. So the metabolites of certain opiates like morphine 3-glucuronide or norepinephrine have been implicated in seizure activity. And finally, this one point that I'm going to discuss, this is a controversial point, and the management of it is controversial. That point is this: withdrawal syndrome due to antagonists mean the counter product to the opioid. So somebody has opioid and you give something like naloxone, for example, that would antagonize or counter the effect of opioid. So usage of antagonists or abstinence from opioid, that is somebody who was taking opioids and now they're not taking it, they would have withdrawal effect. So that is not controversial. I'm going to go to the management, which is controversial. In opioid-dependent adults, and infants born to opioid-dependent mothers can result in notable EEG activation, tremors, and rigidity. So those adults who are opioid dependent or children born to the mothers who are opioid dependent, when opioids are withdrawn, either they are abstaining or there are antagonists to opioid given, then they have this increased EEG activity, tremors, and rigidity. Now, the management of such activation is subject to controversy, and anticonvulsants agents may not always effectively suppress opioid-induced seizures. This is a very important point. Anticonvulsant. Of course, as a professional, you would say that, well, if somebody has convulsions or seizures, I should give them anticonvulsants. However, if these are triggered because of abstinence or withdrawal or antagonism of opioid, then anticonvulsants may not always work. So that's a very important clinical pearl to keep in mind. Cough. And there are doctors who actually use mild opioid doses for cough suppression in patients with chronic coughs. So coughing is protective reflex. So it's a reflex. It's out of our control. We just cough. And it is a protective reflex triggered by airway irritation involving the forceful expulsion of air against a temporarily closed glottis. So here the glottis would close temporarily and we would build up force of air behind that, and then we would just explosively release it when the glottis would open. That forceful release would kind of clear our airways, or that is the body's idea. In some people, there is just cough when there is no need for it. This reflex is complex, involving both the central and peripheral nervous system and the bronchial smooth muscles. So think about it. It is out of our control. It is an involuntary thing. It's a reflex. Brain is taking part in it. Peripheral nerves are taking part in it. And the muscles are taking of the bronchi are taking part. Your chest wall is taking part in it. Your respiratory system is taking part, right? It's a very complex mechanism of coughing. Morphine and related opioids suppress the cough reflex, partly through a direct effect on the cough center in medulla. Now, hear this one out. The clinical pearl is this. This suppression does not necessarily affect the protective glottal function. So glottis has a protective function. Its protective function is that it would not let the fluids and the food to enter our airways. It would kind of close the airways so that the food and fluids can go into the stomach side, into the GIT. So glottis is involved in cough as well, plus glottis has a protective effect. So if morphine, when given, reduces the cough reflex, does it also affect glottis? Will we have a problem with fluids now entering our airways or food entering our airways because glottis is also kind of less working? That is what they're clarifying. When morphine is used for cough, glottis is not affected. So patient's protection of food going into the airways is present. It is important to note that the depression of respiration and coughing are not always correlated, and there are effective antitussive agents that don't depress respiration. So they are clarifying two things over here. One, they clarified that if you're using opioids for suppressing cough, the glottal function will remain intact and patient can continue to have their food and liquids. Second thing that they're talking about is that would you now worry that my patient would start having respiratory depression? So that is what they're clarifying. It's important to note that the depression of respiration and coughing are not always correlated. And there are effective antitussives are the one that are against cough or they suppress cough. There are effective antitussive agents that don't depress respiration. So which agents, the antitussives could be opioid based or not, but they could control the cough without causing any depression of respiration. Nauseant and emetic effect. So nausea is that feeling of vomiting and that, strange feeling that we get. Emetic effect is emesis or vomiting. Nausea and vomiting induced by morphine-like drugs are side effects resulting from the direct stimulation of chemoreceptor trigger zone for emesis in the area postrema of medulla. Recall that diagram of medulla where we talked about carbon dioxide and hydrogen ion production, and then hydrogen ion are then sensed. That is the interior part, correct, of the medulla. Similarly, there is a CTZ zone on medulla that helps with the emesis or vomiting. Opioids directly stimulate CTZ area or the vomiting area in the medulla, which then causes nausea and vomiting. Virtually all clinically effective agonists produce some level of nausea and vomiting. So, number one, how do opioids cause nausea and vomiting? By acting directly on medulla on the CTZ zone. Number two, all effective opioid drugs, agonists, produce some level of nausea and vomiting. Thirdly, it is possible that patient at rest. So imagine if I took opioids and I am at rest, I'm not moving around, I'm not traveling. I may not have as much nausea and vomiting compared to ambulatory patients or patients who are moving. So approximately 40% nausea occurs in approximately 40% and vomiting in 15% of ambulatory patients treated with analgesic doses. So those who are given analgesic dose, so again, we are talking therapeutic dose. We're not talking overdose. Therapeutic dose, those patients who have taken it and they're moving about, 40% of them will have nausea or likely to have nausea, and 15% of them can likely have vomiting. Morphine and related synthetic analgesics heighten vestibular sensitivity. This is another important area. Remember that in our inner ears, we have a mechanism for balance. And if we have a problem with that balance mechanism, our brain cannot correlate what our ears are saying versus what our eyes are saying and what our body is saying. So imagine for a second, right now I'm sitting here in front of you and my body is sending proprioception signals or the signal of the position to my brain. So brain knows that Mubin is sitting up in this state and here are his hands and here are his legs and all that. This position information is verified by my eyes and the view that is coming in from the eyes. Brain is able to double check and say, okay, eyes are also saying that Mubin is sitting up. Then it is triple checked by the inner ears that are saying, yeah, Mubin is sitting upright and this is his position. Inner ears have three semicircular canals. They can tell the brain the exact angle at which we are and even at the speed of movement that we have. So these three systems correlate with each other. Brain receives messages from all these three to double check and triple check and say, okay, I know that this person is in this position. Now imagine, so let me back up for a second. Any two of these systems have to work correctly for brain to be able to understand what is our position and to verify that that position is the correct position. For example, imagine that the inner ear isn't working correctly, let's say under the influence of opioids. Now, inner ear might not provide the correct angle measurements to our brain. So, for example, I'm sitting upright, but the inner ear or the vestibular area has become more sensitive. So, it is providing some messages that are saying maybe he's slightly tilted. So, ears are saying he's tilted, eyes are saying he's straight, proprioceptive messages are saying he's straight. So, brain is able to double check but not triple check. Most of the time brain would be able to handle it and say, okay, I can ignore what inner ears is saying. But imagine while I'm speaking with you, I close my eyes. As soon as I closed my eyes, I have taken one system off and I'm left with proprioception and vestibular system or the ear system, just left with these two. Eyes are closed. Now all of a sudden, out of these two, they are not aligning with each other, and brain would immediately produce a sense of nausea and vomiting. Why? Because brain would think that we have become poisoned. Because of that, our senses are not working correctly. And the solution for that, for brain, is to cause nausea and vomiting to push or eject the poison from our body. This is why people who develop motion sickness, they develop nausea and vomiting. It is really their brain trying to throw the poison out. So here, when we use opioids, morphine and related synthetic analgesics, heighten vestibular sensitivity. They make inner ears really sensitive, contributing to these effects. And the patient would start having nausea and vomiting. Additionally, a part of the nausea may stem from post-operative gastric stasis, further exacerbated by analgesic dose of morphine. So imagine somebody had a surgery. After their surgery, their stomach isn't, the GIT may not be working as efficiently as it was working before. So there is stasis. when our GIT is under stasis, it produces nausea feeling as well. As long as the GIT is moving, or the peristalsis, the movement in the GIT, is moving away from the mouth and towards the anus, then we feel fine. As soon as that movement reduces, we start feeling nausea. And if that movement reverses, we would get vomiting. So in post-operative patients, it is possible that they have stasis of their stomach, that is reduced movement, which causes nausea. On top of that, if they're given morphine, which itself causes nausea as well by working directly on the medulla, then the effect would become exacerbated. So for nausea and vomiting, it is a side effect. And now what are the mechanism? What are the areas? Medulla, chemoreceptor trigger zone, or CTZ, that is one. Then the effect on the vestibular system, 2, ear, and the effect on the GIT or the stomach, 3. So these are the 3 reasons that side effect of nausea and vomiting can occur. And that is the discussion. Thank you very much for listening in.